Welcome to week 11 of Pharmacology for Vocational Nursing 1. This week we're going to study fluids and electrolytes with regards to pharmacology. We'll talk about fluid volume and the compartments in the body and the disorders associated with fluid and electrolyte imbalance, as well as the IV fluids and how we treat those disorders. So let's get started. So resources say 50 to 70% of the body is water. That's an average across the lifespan. 60% of the human body, the adult human body, is water. So what does that mean? Well, this means that fluid is about 40 liters in the average adult. 2/3 of that 40 liters would be about 25 liters. That's housed in the intracellular fluid. So it's represented by that green box on the diagram there. The other 15 liters then is in the extracellular fluid, or 1/3. So that 15 liters is further broken down into two compartments. The interstitial fluid, which is about 2/3 of the extracellular fluid, or we could say about 10 liters, and then the plasma volume, which is 1/3 of that extracellular fluid, or about 5 liters. The intracellular fluid, that green box there, is mostly water, and it's rich in potassium, magnesium, hydrogen phosphate, sulfate, and protein anions. The extracellular fluid, that would be including the plasma volume and interstitial fluid, contains more sodium, chloride, bicarbonate, and calcium. So when we look at fluid balance, we're also looking at a division of location in terms of where is it inside the vascular bed or outside the vascular bed. Well, intravascular fluid is that fluid that's inside the blood vessels. Extravascular fluid is that fluid outside the blood vessels, things like lymph or cerebrospinal fluid. When we're looking at extravascular volume, these things are kept in balance by the plasma and the interstitial fluid, the spaces between the cells. So there's a marriage, there's a movement going back and forth between this space. The same thing with the extracellular volume. That is a movement from interstitial fluid to intracellular fluid. So volume is affected by where the fluid is located. Now, the difference between plasma and interstitial fluid is that the plasma contains more protein. Most of the other solutes are found in similar concentrations in both plasma and the interstitial fluid. So the osmotic pressure is more often a term that we use to express concentration. Strictly speaking, it's the pressure that is needed to prevent a pure solvent from passing into one to another solution by osmosis. But plasma has a protein concentration that's about 4 times greater than the interstitial fluid. So it exerts a constant osmotic pressure. This pressure, because it's the proteins and they have a large molecular weight, they can displace the water molecules. So that's called colloid osmotic or oncotic pressure. This creates a relative water volume deficit at the capillary beds. These protein molecules that create the oncotic pressure can't pass through the vessels as readily as the fluid does. So the difference in concentration means that the fluid flows from the areas of low concentration in the interstitial fluid to the areas of higher concentration inside the blood vessels to create an isotonic environment. Isotonic means that the concentration of solutes are present in the solutions, so they're exerting the same osmotic pressure. So then for maintaining extracellular volume, you'll see that there's a movement between interstitial fluid and the intracellular fluid, with that intracellular fluid being the fluid inside the cells or inside the plasma membrane. So there's an exchange between what's outside the cell and what's inside the cell through that semi-permeable membrane. Now, those plasma proteins, most notably albumin, exert this constant oncotic pressure and prevent the leakage of too much plasma through the capillaries and into the tissues. Because those proteins are suspended in the plasma, They are in a colloid state, and it's this colloid oncotic pressure that's normally around 20 millimeters of mercury. The interstitial fluid exerts hydrostatic pressure. Hydro meaning water and static meaning not moving. So hydrostatic pressure is that pressure which is exerted by a fluid at equilibrium. It is this hydrostatic pressure that increases filtration by pushing the fluid and solutes out of the capillaries. So how can I think of it in an easier way? Well, think of it like this. Colloid oncotic pressure pulls fluids into the capillaries or keeps it from leaving, whereas hydrostatic pressure pushes fluids and solutes out. The hydrostatic pressure is normally around 17 millimeters of mercury. Wow. Body never ceases to amaze me. We're just wonderfully made. It knows where to keep those fluids and how to move them around. It's usually able to maintain volumes in the spaces where they need to be and manages this through intake and excretion. You know what I'm going to say, until it doesn't, right? So what happens when it doesn't? Well, when fluid volume gains exceed loss, there's fluid volume excess. Fluid volume excess will often accumulate in the interstitial spaces, such as the pericardial sac, the pleural spaces, the peritoneal cavity, joint capsules, or the lower extremities, causing what we know as edema. The opposite phenomena is when the fluid volume loss exceeds the gain, and this is when then we have a fluid volume deficit. Death will often occur when 20 to 25% of the total body water is lost. So it's real important to replace fluid volume. To replace fluid volume, we have three categories of IV fluids that can be used. These are crystalloids, colloids, and blood products. We'll talk about each of them individually in just a few minutes, but I don't want to forget to mention acid-base because it's so important to fluid balance. You will recall that it's regulated primarily through the hydrogen buffer systems, through respiration and kidney function. So you're asking yourself, what? I'm still not making the connection. Well, think of it this way. Acids are electrolytes that release positively charged hydrogen atoms. Those would be cations, right? When they're dissolved in water. Bases are electrolytes that release negatively charged hydroxide ions. Those would be anions when they're dissolved in water. Acid-base balance is primarily regulated by the concentration of hydrogen, or the pH level, in the body fluids, and especially in the extracellular fluid. So let's talk about those fluids that we'll give. Crystalloids. Crystalloids are solutions containing fluid and electrolytes that are normally found in the body. They don't contain any proteins or colloids, and there's no risk for viral transmission, anaphylaxis, or alteration in a coagulation profile. You'll recognize these fluids as things like normal saline, half normal saline, hypertonic saline, lactated ringers, D5W, which is 5% dextrose in water. Our crystalloids are better for treating hydration rather than expanding plasma volume. We can also use them as maintenance fluids to compensate for insensible losses, or replace fluids to manage fluid and electrolyte disturbances and to promote urinary flow. Indications for crystalloids include acute liver failure, acute nephrosis, ARDS or adult respiratory distress syndrome, burns, cardiopulmonary bypass, hypoproteinemia, renal dialysis, reduction for the risk of deep vein thrombosis or DVT, and shock. Crystalloids are fairly safe, but to be effective, they have to be used in large volumes. So because of that, they may cause edema, especially peripheral or pulmonary edema. Because they have no proteins, they may not stay in the intravascular space. They can leak out into the tissues, and that's what causes the edema. They may dilute those plasma proteins, thereby reducing the colloid oncotic pressure, and the effects of these crystalloid fluids are pretty short-lived. prolonged infusions of them may worsen alkalosis or acidosis, as well as result in fluid overload. Let's differentiate these from colloids. Now, colloids are protein substances, right? They increase the colloid oncotic pressure. Normally, our body does this by moving 3 blood proteins, albumin, globulin, and fibrinogen. And so when these proteins are low, especially the albumin, the fluid will shift out of the blood vessels and into the tissues. So we want to move the fluid back. We will use albumin 5% or 25% from human donors, a dextran 40, 70, or 75, which is a glucose solution, or hetastarch, which is a synthetic solution derived from cornstarch. These are used as colloid replacement and to increase the colloid oncotic pressure. These are relatively safe, but they do have some adverse effects. Remember one of those proteins? Fibrinogen, right? So because of the change in this oncotic pressure, and we already have a low fibrinogen, they can cause an altered coagulation and result in bleeding. They really have no clotting factors or oxygen carrying capacity. Excuse me. But they do help us to keep those fluids, they help us to keep those fluids in the right space. Now, we also give something called dextran. Rarely, however, it can cause anaphylaxis or renal failure. It's a complex polysaccharide that's derived from the condensation of glucose, so it has a really high molecular weight, and sometimes that is what leads to that problem. We're going to take a break and go to another audio clip, so I'll see you back in a few minutes.